our eminent panelists and respected participants to this international webinar. We at Alembic are always at forefront when it comes to the knowledge sharing and dissemination initiatives. In our efforts to do so, I am very happy to present the first of a series of knowledge enriching program powered by Alembic called Knowledge Beyond Boundaries. We truly believe that knowledge is a boundless and needs to be shared across the globe. Through this initiative, Alembic shall bring renowned international and national faculties who will share their views and experience on various topics of gynecological interest. Today's topic is non-invasive therapy of managing fibroids. Let me not stand between you and our learned faculties. I now hand you over to the moderator of the webinar, Dr. Niranjan Chavan. Dr. Niranjan Chavan is a professor and unit chief of LTMMC and LTMG Hospital, Mumbai. Sir, over to you. Thank you very much.
Hello. Good morning, ladies and gentlemen, and all our viewers across Algiers, Singapore, China, France, Senegal, Belgium, Tunisia, Mali, Morocco, and of course, our own India. Welcome to the Times of Gynecology. The live webinar is on. I thank Alembic and Science Integra and Maharashtra chapter of Indian Association of Gynecological Endoscopies to be a part of this international wonderful TOG webinar titled Non-Invasive Therapy of Managing Fibroids. Today, I take the pleasure to welcome Dr. Keen Whye from Singapore. He is consultant obstetrician and gynecologist having private practice at Gleneagles Medical Center, Singapore. He was also the past president of ONG Society of Singapore and has been awarded many awards, namely the National Serviceman of the Year Award in 1996 for his leadership and dedication to the Singapore Armed Forces Medical Services. Dr. Lee has been a medical volunteer with Singapore International Foundation and has participated in medical mission during the aftermath of the tsunami in 2005. His field of interest is non-invasive, high-focused ultrasound treatment of fibroids and endometriosis, and he's going to share his knowledge of more and experience of more than 35 years to all of us. Welcome, Dr. Lee.
Thank you.
Along with him is our own Dr. Narendra Malhotra from India. Who doesn't know Dr. Narendra Malhotra? Our audience is eagerly waiting to hear both these stalwarts. We all know him as the past president of ISAR, ISPAT, and FOXY. Presently, he is a member of FIGO Guidelines Committee. He is also the Dean of ICMU and has, to his credit, many orations and scientific papers been published in international and national journals. He is also the professor of Dubrovnik International University and he conducts Iron Donald CMEs all over the world. He is a pioneer in ultrasound and we all are waiting to eagerly hear from both of them. Now, let me also tell you, when I say our audiences is waiting, you all should know that today we have a live audience of 2,200 doctors across the globe. And before I hand over to Dr. Lee today, I am happy to acknowledge that we are celebrating the Earth Day today. We living Homo sapiens thank this earth for letting us live. And I have no words but a video to showcase the beauty of nature which we need to preserve. I present wonderful video. Ali.
Thank you. Somebody have to, okay. Can you hear me?
Yes, sir, we can hear you. We will have the screen sharing now.
Okay, I must say this is the first time I'm making a presentation, not looking at a live audience, but actually I'm talking to the laptop. So if you are as unfamiliar as I am, I really beg your pardon. So first I must thank the organizing committee, especially the Federation O&G Society India, Foxy Mumbai Society, and of course the Maharashtra chapter of Indian Association of Gynae Endoscopies, and the people who are behind the scene to organize this seminar. My topic today is from minimally invasive surgery to non-invasive virtual surgery for fibroids and adenomyosis, called HIFU. It is the high intensity focused ultrasound. Introduce the society which I'm very close to. I'm a co-founder of the Asian Pacific Association of Gynecology Endoscopies. This is a photo taken in 2003 in Taipei. I'm not sure whether you can see, but this is Dr. Prashant. This is Dr. Harry Rich. This is, I think, Dr. Bruce. And this is the chairman of APAGE, Dr. Li Qilong. Behind are doctors from Japan, Hoshiai, I think Dr. Nam from Korea, Dr. Endao from Japan, and Yong Pamo, and right behind, I'm there. A few APAGE members, which is a recent photograph taken in Chongqing this year. This is Dr. Jane from Taiwan. This is Dr. Dr. Salva, myself, Dr. Felix Wong, Dr. Li Qilong, the chairperson. This is Dr. Hugo Verhoeven from Germany. Okay, so the subject or the machine we are talking about is produced by the company called HIFU, but actually it is, it looks like MRI, but it's not an MRI. The patient lies on top of this table, face down, prone position, and this is a water container or water tank. There are few monitors here. This is the ultrasound monitor. This is the MRI monitor. And together, when we do the surgery or the procedure, we always talk to the patient and we always keep track of the position of the fibroid or the adenomyosis. Let me show you a little clip of the physics behind it. This is sound. So sound has no radiation.
An ultrasound beam can be brought to a tight focus at a distance from its source, with sufficient energy concentrated within the focus. The cells lying within will be killed without damaging the surrounding tissues.
It's about 3 centimeters
High intensity
by 1
focus
centimeter.
ultrasound, HIFU, is, therefore, a non-invasive method of producing selective.
Okay, so this is the treatment head. This is the transducer, and this bowl is where it focuses the ultrasound to a beam, to a focal point. Okay, how I got started was in a hot summer in July 2017. I must say I was very reluctant to go because it's summer and it's very hot in Chongqing. But lo and behold, when I was there, I met a lot of friends from all over the world. In the background, doctors from Spain and Germany, and this is Dr. Anthony from Spain, Dr. Felix Wong, and the 2 doctors, my friends from Thailand. Now, on the first visit there, it is the hospital. The whole hospital is built around the HIFU technology. This is one of the trainers, and they will show me, what it is like when you use HIFU to treat a piece of meat. And on this little simple workshop here, they will show you how the HIFU sound when it focuses on the B away from it, even when it's above the transducer, there's you don't get the burns. Okay. So what is therapeutic HIFU used for? It is used for treatment for uterine tissue, uterine tumors, breast tumors, liver, especially cancers that are not responding well to chemotherapy, pancreas, for pain control in those who are not amenable to surgery, kidney tumors, bone, and of course the prostate in men. Now in gynecology, the focus is on uterine fibroids and adenomyosis. I must say I have no experience on placenta accreta, cesarean section, scar pregnancy, and abdominal wall endometriosis. But in China, they have lots of. This is a picture from laparotomy to laparoscopy or keel surgery, whereby we try to minimize the scars to reduce pain. And the evolution for me, which is very exciting, is from somebody who's trained in basic laparotomy to laparoscopy and now to really Scarless surgery. Even when we talk about single port surgery, is a cosmetic hidden scar. It is not truly a Scarless surgery. Now, I then learned there are different versions of therapeutic HIFU. I put the adjective therapeutic because very often people get confused with aesthetic HIFU. So I'm talking about therapeutic HIFU, and there are actually two different machines or two different modes of delivery. One is MRI guided, the other one is ultrasound guided. The difference in MRI guided, resolution is much better. There's the temperature control, but in ultrasound guided, the resolution is poorer. There's no temperature control, but the other advantages are the movement. In other words, the treatment head is much better. The patient can be positioned at different angles, whereas in an MRI HIFU, the patient is sent into the chamber or the tunnel. So there's limitation of movement of both the transducer and the position of the patient. Of course, there's noise from the MRI machines. Treatment time is longer. For the same fibroid, the treatment time is longer in MRI because the power that they can produce is much less than the power that they can produce if you used ultrasound guided HIFU. Next, they use a terminology called non-perfused volume. Just take it from me that non-perfused volume is this degree of ablation of tissue. Yes, in MRI guided HIFU, you only have 20 to 50% ablation. But in ultrasound guided HIFU, it's 80 to 90%. So that's, is somebody asking me a question? Sorry. Okay, the treatment cost, of course, is higher in MRI guided HIFU because you occupy the duration of use of the MRI machine compared to an ultrasound HIFU. Now, what is most important, most interesting to me that I was bowled over is in MRI guided HIFU, you need the presence of your colleague, which is usually a radiologist, whereas in ultrasound guided HIFU, you yourself, a gynecologist or any trained doctor, can perform the surgery. So in summary, here, it was because any gynecologist or any medical doctor can handle the machines that I'm very interested in learning. And this started whole chain reaction, my thought process, and I think it's going to be a revolution, especially to the younger colleagues. And I am postulating there will be a lot of disruption to the way we operate or treat our patients. Now, MRI guided HIFU is produced by two different companies that I know of. One is from USA, and the company is called Insightec. The other company is Philips from Europe. And in total, as of end of December 2018, they have done 4,000 cases worldwide. The ultrasound guided HIFU has been used in more than 26 countries and regions. In total, they have already done 120,000 cases as of end 2018, whereas 4,000 cases are done with MRI guided HIFU. And sometimes when you go into the literature, they were still saying that it's on the research program, or it's still a research modality. I'll show you a simple clip of the procedure, and you understand how it is done. Just a short 1-minute video. Patient comes in, patient actually walks in, and this is the bed she lies on in prone position. Once the monitors are set up, notice this is the fibroid, and we check it with an MRI image. This is the MRI image. And this is Dr. Tang, and this is the live ultrasound monitor. So you notice the doctor is always in communication with the patient. The patient is not under general anesthesia. This is an important arrangement because the patient can feedback to the doctor whether she's feeling pain on the legs or pain on the skin. So it is there's a communication. Okay, so why do I learn to use the ultrasound guided HIFU? Because the procedure is done by any doctor. The duration of the ultrasound HIFU procedure is independent of the machine. So the MRI facility can be put to better use. So you don't have to occupy the MRI for 2 or 3 hours. So the MRI can be used by your other surgeons or other doctors in the hospital. In so doing, the machine can be housed in a day surgery center, outpatient, and in fact, when I visited the Korean colleagues, they actually put it on a medical floor in a shopping center. Now, I took one of the early papers. This is done in 2006 to 2009. This paper is done in Chongqing, the university. 757 patients, 1,000 over fibroids. And the size of the fibroid is about 5 to 6 centimeters. They managed to achieve a success ratio of ablation about 80%. Anything more than 75% is considered good. And they plot a graph to show that symptoms like pain and menorrhagia has improved after about 6 months. And the size of fibroids, because these are the experts, they've done a lot. So they're able to reduce the size of the fibroids by about 50% by 6 months and about 90% after 1 to 2 years. Are there research papers on HIFU in medicine? Actually, plenty. But as you know, most of us are English educated. And I would say some of us are biased in that we only read English journals and literatures. Okay. I put up a few from British Journal of ONG. This is written by a professor in Hong Kong. And there's a paper from Germany. And this is a paper from Japan, and so on and so forth. And the most recent paper that came out from UK, NICE, National Institute of Healthcare, has actually stated they now accept ultrasound guided HIFU as a treatment technology for fibroids. Of course, it has a lot of safeguards and cautions of how the doctor on embarking with using HIFU should discuss with the patient, like all the other modalities, like all surgeries. Okay, and HIFU, the company, has research collaboration with Professor David Cranston. He's the professor of surgery, Oxford University, and he has a team that looks into HIFU for gynecology, renal, neurosurgery, breast, pancreas, sarcoma, prostate, and even drug delivery. And I know HIFU is now used for palliative treatment of liver cancer. Even in Southeast Asia, in Myanmar, they're doing it. And I met a young doctor from France. They're using HIFU now for deep infiltrating endometriosis. Okay, this is a picture taken last year in Chongqing, whereby Professor David Cranston and Dr. Li Qilong signed a memorandum of understanding to cover training, education, research, and certification of HIFU practitioners. Now, what's the advantage? The advantage to us is because as gynecologists or any trained doctor, you need not refer the patients to the interventional radiology. In other words, you do not need to trouble your friends or in X-ray department to sit with you for hours using the MRI machine. As most gynaes are trained in ultrasound scans, I think adopting HIFU is much easier than, say, picking up laparoscopy. Now, what are the complication rates and side effects? Actually, very low compared to conventional surgeries for fibroids and adenomyosis. Let me show you this paper, which is written very recent, 2018. They have over 27,000 patients. In other words, not 2,700 patients, but 27,000 patients. And they're able to collect the data of these 27,000 patients. Of interest to us as surgeons, we look at, especially laparoscopic surgeons, we look at bowel injury, which I see 4 out of 27,000 patients, which comes to a rate of about 0.048%. I don't see any vessel or blood vessel injury in this group. Now, if I may show you this chart of mine, which I've been using for many years, the risk of bowel injury in laparoscopy is 0.04% to 0.3%. If you compare this with the risk of HIFU bowel injury, it's 0.01%. In other words, comparatively speaking, anybody doing the conventional surgeries like keyhole or open surgery, you have actually 4 times more risk or 30 times more risk compared to HIFU. And if you think that by doing an open surgery is safer, that is different. The open surgery colleagues always say that it's dangerous to do laparoscopy, but the truth is, in laparotomy, maybe because you can't embark on laparoscopy, you have more bowel adhesions and all this, and so you actually have more incidence of bowel injury. This is a paper I dug up to show, and this is a very recent paper written in 2017. Well, the conclusion is 17 of the 79 patients treated with HIFU, anti-Mullerian hormone is not affected. And this is a paper to show that of also in 2017, of the 78 patients that has received HIFU, they achieved 71%, 71 live births. And conclusion is it could significantly reduce the preparation period for pregnancy after HIFU. It can also improve fertility of patients with a history of infertility, abnormal pregnancy, and childbearing with no obstetric risk. Okay, I like this picture. So finally, in July 2018, The Sound of the Music arrives in Singapore. This is the first patient we did with my group of SOG gynecologists on the 16th of July, 2018. I think my young colleague, Dr. Hong, is there. Okay, I'm halfway through. It shows me I'm halfway through. I'd like to show you this video of my first patient. Uh-oh. No, I think it's, oops. I'm so sorry. I don't know what happened to the screen.
You can please continue. You can please continue.
Okay,
Dr.
sure,
Lee,
sure.
please continue. Sure. The video will be on. It will start.
Okay.
Thank you.
So yeah, that was the first case in 2018 of a patient of mine who have read about HIFU, and this patient is about 41 years old, and she was following another health screening center to screen her, follow on the growth of her fibroid. Her fibroid was growing at the rate of about 1 centimeters every year. Like all good doctors, we will say, yes, if you're just growing at 1 centimeters every year, but it's only about 3 centimeters. So she was told to observe, which is correct. We all do that when the fibroid is small. Lo and behold, her bleeding, her periods become heavier and her hemoglobin dropped. That's when somebody advised her to remove the fibroid or to remove the womb, because the same story goes, you have finished your completed your family and think the womb is of no necessity to you. But you see, she's a very active person. Well, I was trying to move a bit faster, and that's where, okay. Now, what I want you to see is this green spot. When I fire, it turns red. That means I have activated the fire button and the treatment button. And look at this turning white. And that's what we want to see. That means we have ablated this point. And this point is about 3 mm by 1 mm. This is the bladder and this is the bowel. And look how we managed to get the bowel away from the line of fire. And you can see the excitement in the background of somebody who was watching behind and exclaiming. Okay, I think that's enough. We'll go to, let me stop this. How do I stop this? Okay, let me go to the next slide. I mean, you can just imagine the excitement. I always say, you can just imagine the excitement. The excitement is, it's like scoring your first goal in soccer as a schoolboy, or holding a girl's hand for the first time. That is the excitement you get. And this is a patient who, the same patient who showed me this picture. I asked her to stay at home for a week, but on the second post-op day, I did her on Monday. Wednesday, she went rock climbing. I said, girl, please be careful, because this is something I'm not sure of the recovery. I know you're well, but be careful. But it's good for her to show me this. And then 5 months later, she showed me her snowboarding somewhere in the Northern Hemisphere. Now, this is a MRI, which is pre-HIFU. It's about 48 by 37 mm. After about a year, I repeated the MRI. It has shrunk to 38 by 30.7 mm. Frankly, if I use an ultrasound, I could not really make up the delineation of the fibroid. So she was very happy. 1 year later, her periods are normal, hemoglobin improved. This is a 54-year-old lady, has pain and heavy periods due to fibroids. Again, she was being looked after and monitored on the growth of the fibroid until it became about 5 centimeters, and her doctor asked her to remove the womb. Now, 54 years old, in this present day and age, is different from 54 years old in the 70s or when I was a medical student. The 54 years old lady dresses like a 34 years old and behaves sometimes like a 14 years old. So we have to change our concept, how we advise patients. 9 months later, after HIFU, the fibroid strength, and I just want to repeat the hormone profile because somebody commented at 54 years old, she's likely to go into menopause. So I repeated the hormone profile. It is still like a young lady in early or late 40s. So again, really it depends on the patient and the outlook. I think gone are those days where we said the ovaries belong to the pathology department or the formalin bottle. I think we have to tailor our management to change of the times. Okay, so I call this a very disruptive technology. So more women will choose non-invasive surgery over the open surgery or MIS surgery. Just like years ago, people like us have switched from MIS to open surgeries in preference to open surgeries. Then the next, you can do away with the headache of having morcellation and barbed wires to stitch the open womb of a fibroid. And in particular, I think this is really a hope for patients with adenomyosis, which has always been a headache to even the very experienced gynecologists. And the fact is true that now, because I don't do IVF, my colleagues in IVF department refer the adenomyosis patients to me. So the advantages are straightforward, being no surgery, no incisions, short hospital stay, no GA, so the patient recovers faster, less or minimal collateral damage, minimal discomfort. And what is important to young ladies is you can preserve the uterine functions. And just for the sake of this webinar, I actually call up the chief of the trainers, Professor Zhang Lian. Professor Zhang Lian has 60 trainees or trainers under him. Every trainer must have done 1,000 HIFU cases before become a trainer. So I call him up, I asked him, have you come across any risk of rupture in pregnancy after HIFU? The answer is no. And of course, the patient can go back to exercise and work earlier. Quality of life returns much faster. And very important for those of you who own hospitals and have your own day surgery centers, the cost is less than an open surgery or myomectomy. And for those patients who fear of surgery, this is a good alternative. And of course, there are no scars. Now, for the hospital administrators, you find that the use of operation rooms is less. You can use it for other surgeons, and this is definitely a cost saving to the hospital. You will be using less of surgical instruments and disposables. You'll be using less of suture material, and you'll be using less of barbed wires. Remember this picture? A colleague in America, Amy Reed, dies at the age of 44 because of an undetected fibroid that turns out to be a sarcoma, and everybody blames the morcellator. I don't think so, because I think it was in good faith that the doctor chose to perform a laparoscopic surgery for her. And unfortunately, it has spread the cancer cells. But let's face it, when we do myomectomy, whether open or laparoscopy, the first thing we do is to cut into the serosa layer to look for the fibroid, and then we enucleate the fibroids. During this process, if it's sarcoma, the cancer cells would have spread like the virus, like the coronavirus. And all these bags are used to mitigate the problem of sarcoma or cancer cell spreads. But I find that it's really gymnastics to all of us. Surgeries for fibroids and adenomyosis will drop. This is my postulations. Drugs to reduce the size of fibroids like ulipistol acetate, I think will suffer the usage. Anti-adhesion products will not be so well used. Drugs like GnRH agonists will be needed for preparation of the fibroid or the adenomyosis, pre and post. MRI will be used by more gynecologists now. The contrast media usage will go up. And these two modalities, radiofrequency and uterine artery embolization, will face competition from the HIFU technology. And all these products, TrueClear, Bicati, Myosure, endometrial ablation, which we use to reduce bleeding or resect submucous fibroid, will be affected. This is a picture of submucous fibroids. My doctor sent it to me, Dr. YG Tong of Singapore, 4 centimeters after HIFU, the fibroid just came out vaginally. This is a picture of a submucous fibroid I did for a nurse, and she showed me the bits and pieces of fibroid that dropped out, and she took a picture on the sanitary towel. And this is a very interesting case. 11th July 2019, last year, I did a hysteroscopy before HIFU, and the only sign of an intramural fibroid anteriorly was this bump here. Even when I released the pressure, this is the intramural fibroid. 9 months later, post-HIFU, the intramural fibroid became submucous. It comes down, I think, from here. You can see it. This is the site of it. You can see the angle, the acute angle in which it goes to this, the endometrial layer. This is the other side of it. This is the other side of it. And this is from, again, coming down from the top. So what I'm going to do, well, I'm going to wait for it to string until it's of 3 centimeters and remove it with a resectoscope. Now, what about our maternal fetal medical ultrasound subspecialists, our colleagues who prefers to stay out of the operating room and prefers to perform ultrasound? It is going to be very interesting for them because they are so good with medical ultrasound that I think more of them will jump onto the bandwagon to be a surgeon again without needing to scrub in the former operating theater. So what are the qualities of a HIFU gynecologist? I've listed a few. If you can have good spatial orientation, as when you drive your car and read the road map, if you have pelvic ultrasound experience, if you have good interpretation of MRI, that will help. Oh, by the way, when I left medical school, I only know how to read chest X-rays, abdominal X-rays. This is something new to me. So I pick it up when I learned how to use the HIFU. You must have patience because it's not going to go in and remove the fibroid in less than an hour. You must have patience. And very important to all of us who's in HIFU, you must abide by safety guidelines. So we cannot afford to have cowboys learning to do HIFU, because if you don't look good in a complication, the rest of us do not look good at all. Okay, this reminds me I have to move faster. I have last 10 slides. Will HIFU replace open or minimally invasive surgery? The answer is no. This is my patient, again, 40 years old. I treated her for adenomyosis. 6 months later, her pain has improved. But again, I'm not happy because the size of the adenomyosis is about the same. Although the complaints are much better, but because this is diffuse in nature and she's young, probably in about 3 or 4 years' time, this will regrow. So again, I cannot say HIFU will treat everything, but in this case, I may need to go in with laparotomy to either remove the uterus or do a wedge resection of the adenomyosis. So It is good to learn a new procedure as another alternative to offer to patients, or just to inform patients that there is another method to treat her fibroid or adenomyosis, and to refer to the appropriate HIFU department. This, I always say, is the spirit of good doctoring. Long ago, as physicians, that's how we listen to chest sounds. In the Victorian era, this is how we palpate gynecologically. And Dr. Leonard, a French physician, used a tube to listen to chest sounds, and was only 132 years later that the tube became our modern day stethoscope, 132 years. The history of HIFU started briefly in 1988. Professor Wang sets up a research team on HIFU applications in Chongqing. It was not until year 2000 that HIFU was approved by Chinese government to treat tumors. In fact, the first few treatment was on cancer of the bones. This is Professor Wang Zibiao. So from 1988 to 2000, just a span of 12 years, he's able to convert a natural knife found in nature in Chongqing to a modern HIFU virtual knife for the benefit of women. So in conclusion, this is my last slide. And I believe for the preservation of femininity and fertility, right now, HIFU is an excellent alternative for the treatment of fibroids and adenomyosis. Thank you very much.
Thank you, Professor Lee. It was an excellent presentation given by you, and we are very thankful to you for a wonderful overview of the Medical Chongqing University and explaining the details of HIFU, how it was founded by Professor Wong, and how we have taken it to the pinnacle heights. And I'm very happy to share with the viewers that we have got more than 5,100 viewers from all these countries. Oh my God, it has gone, I would like to correct, 5,600 viewers. And they are not only from India, but they are from all these countries which have been with us. I would like to name them: Algeria, Singapore, China, France, Senegal, Belgium, Tunisia, Mali, Morocco, Nepal, Pakistan, Bangladesh, Sri Lanka, and this is great. So we will get back to you, sir, very soon with the questions. Now I welcome Dr. Narendra Malhotra. We call him Dr. NM. NM, sir, the mic is yours to present your wonderful presentation. Eagerly, all of them are waiting for you. Thank you so much.
Thank you, Dr. Niranjan. Thank you, everyone, for inviting me here to be a part of this great webinar. I am indeed indebted to all of you and to this webinar, and to so many people who are here listening to all of us here. Today, as you all heard, it's Earth Day. It's 22nd of April, the 50th Earth Day celebration. And we are celebrating a lockdown. The Earth is locked down by this stupid virus called Corona. And we got to beat this virus somehow. How is the big question which we're going to. The only way it will work is stay at home, stay safe, let the Corona warriors work. The rest of you, please stay home. So today I will be talking on medical management of the uterine fibroids, something in addition or in leaving the surgery behind. We all are very knife-happy people, the gynecologists. And the minute a patient is told you have a fibroid, usually we don't look at the size, anything. And the patient also is being told that you have a fibroid, she will immediately rush to a gynecologist or to a surgeon and demand an operation. And usually they demand for a hysterectomy, remove it. So in India, the prevalence of fibroids is about 37.6% in rural population and 24% in urban population. And significant symptoms are seen in more than 25% of the women. We all know the risk factors: increasing age before menopause, and early menarche if it occurs less than 10 years, family history, nulliparity, high BMI, all that. We have to understand, if we want to understand the medical management, we have to understand the pathophysiology. We know that the fibroid will occur when a single uterine smooth muscle or a connective tissue will replicate until it forms a cluster of cells and then forms a mass, which is different from the normal nearby musculature. It has genetic factors, so it runs in families, and majorly it has hormonal factors. So estrogen, progesterone receptors, then normal uterine tissue, and therefore these areas become more sensitive to these two hormones, and then they develop. So fibroid developing is influenced by hormones, progesterone and progesterone receptors, along with genetic factors and disturbance of the aromatase pathway, and that leads to a most significant factor. So progesterone and its receptors hence represent a very potential target for inhibiting growths of myomas. So that is where the treatment will hold good too. So let's see, if you have a symptomatic fibroid, we can offer them medical treatment, which is non-hormonal or hormonal. That's one pathway. We offer them surgical treatment, which could be open or laparoscopic myomectomy or hysterectomy. Or we could offer them endometrial ablation, TCRE, for correcting the menorrhagia, and hysteroscopic myomectomy if it is submucous. Or we can offer them other modalities, which we have so beautifully just heard Dr. Lee describe: magnetic resonance guided focused ultrasound surgery or ultrasound guided HIFU, plus UAE, that is uterine artery embolization. So that also can be offered. Now, the current therapies which are available, are they satisfactory for us? The management of symptomatic fibroid has been surgical. As I've been telling you, all of us are knife happy, and we go ahead and remove as small as fibroids. And we know that there is no medical treatment which will completely eliminate the fibroid. However, alternate pharmacological treatments have been proposed to control the symptoms. And the choice will depend on age, parity, childbearing, extent and severity, size and number of myomas, proximity of menopause, and risk of malignancy. So we can divide the treatment into expectant and definitive. The expectant treatment is that you have a clinical option for asymptomatic fibroid, a scheduled periodic annual evaluation, and monitor the progression. So if she wants to conceive, she has a small intramural fibroid, or maybe two of them, or a subserous fibroid, just leave them alone, monitor them every year. Or you have a definitive treatment which depends on the symptom, size, location, and the patient age, preservation of fertility, preservation of uterus, availability of the therapy, and experience, all to be taken into account on what to do. So the management options for symptomatic fibroids would be, they can be treated medically, surgically, or in combination of both. And we have a lovely algorithm where the fibroid is being diagnosed by physical examination or ultrasound in symptomatic or asymptomatic. So we divide them into asymptomatic, so it was diagnosed incidentally. And here again, we divide them into less than 14-week size uterus, more than 14-week size. So if it is less than 14-week size uterus, you could put these women, if they're asymptomatic and want to conceive, into an expectant management. Just follow it with periodic evaluation. But if it is more than 14 weeks, then of course we discuss the options, and there is an option of medical management here and an option of surgery to be discussed. While if the fibroid is symptomatic, you have a choice of medical management, or a choice, if the patient wants to conceive or infertile, then we have a choice of leaving it alone with expectant management. But if the fibroid is submucous and distorting the cavity, then we got to remove it hysteroscopy. No confusion there. No confusion in infertility. Surgery if it is big, or surgery if it is intra or submucous. If it is symptomatic and not a very big fibroid and the patient is not wanting surgery right now, or you want to try, then you can offer medical treatment. Currently, many medical treatment we'll just discuss, but here I'm in my algorithm, there are only two GnRH analogs or ulipristal. And if this fails, then the patient goes to surgery. So I would have an algorithm, something like that. Now let's see what are the medical treatments available to us. Firstly, we have to remember, as you can see in the blue square, no medical treatment will completely eliminate the fibroid. Please keep that in mind. No medical treatment completely eliminates a fibroid. You have antiprostaglandins if there is pain. You have GnRH agonists to suppress ovulation and suppress the estrogen progesterone. We have progesterone pills to take care of the bleeding. We have oral contraceptive pills again to take care of the bleeding, menorrhagia, and the fibroid. We have progesterone releasing IUCDs which we can put, and of course we will now discuss progesterone receptor modulators, selective progesterone receptor modulators, and selective estrogen receptor modulators, which would help. The aim of the medical management is that you want to control the menorrhagia, you want to improve the hemoglobin before surgery. So iron therapy is to be given, and the drugs to be tried are, if the patient is bleeding, antifibrinolytic agents, GnRH therapy, danazol, big red, not recommended now, because danazol in the right dose, 600 to 800 milligram daily, will cause irreversible symptoms, masculinizing symptoms to women. So they'll cause facial hair, which will never go away, and they'll cause a very hoarse voice. So we don't want the women to have very hoarse voice. So that we don't want that. So that is out. Clomiphene citrate, the role is questionable. It is a SERM, but the role is questionable. OCPs, yes, they might work to regulate the bleeding, but the fibroids sometimes grow. LNG, IUCDs, if the uterus is not very big, yes, it might work. NSAIDs for pain, and progesterone receptor modulators or progestogens or progesterone like mifepristone or nor derivatives, they are used to regulate the bleeding and control the bleeding. And of course, ulipristal. So fibroid growth is hormone dependent. Medical treatments will mainly involve the hormone manipulation. Objectives of medical treatment, we've already told you, we want to improve the anemia, correct the menorrhagia, and make the patient fit for surgery. Or those patients who are not fit for surgery, they go only on medical treatment in perimenopausal women or high-risk women. And in selected cases of infertility, we reduce the size of the fibroid for a hysteroscopic or a laparoscopic to improve the hysteroscopic or laparoscopic size. So drugs used to reduce the blood, antiprogesterones, mifepristone, danazol, no, big no, GnRH analogs, agonist, antagonist, agonist depots, yes, antagonist depot not yet available, so we are not using that. LNG, IUS, yes, in smaller size uterus, prostaglandin synthetase inhibitors only if there is pain, and progestogens, progesterone receptor modulators, and selective progesterone receptor modulators in the others. So a quick one slide each on each one of them. We have already seen this. Instead of medical management, the patients who can go in for uterine artery embolization, which is a complicated procedure and which will require a radiologist. And you can see that this is catheterized into the uterine artery, and polyvinyl particles are then injected into the anterior branch or even to the branches supplying the fibroids and will cause fibroid. HIFU, such a beautiful lecture on HIFU, and I will not go into the details, but these two are there, which are non-surgical treatment available to certain set of patients or certain group of patients. Antiprogesterone, mifepristone, RU486, anti-abortion pill or whatever. Now this is used to reduce the fibroid size and also the menorrhagia in the dose of 25 to 30 milligrams, but recommended for 3 months. Long time therapy.
Okay. Dr. Niranjan, are you there?
Yeah, hi guys. I think we have lost the connection from Dr. Narendra Malhotra. So we will wait for him to get back. Oh, and we have our special guest, Dr. Manjula Anagani. Who
Hi,
doesn't know Dr. Manjula? Yeah. Welcome. She is our Padma Shri. She is from Hyderabad. She is attached to a very major hospital. And Madam, thank you so much for accepting the invite amongst your busy schedule. I think 2 weeks ago, I was with your colleague from medical intensive department, and we just missed you that time. So, well, there are many questions which have been there, and I would like to say now, Madam and Sir, that Narendra Malhotra Sir will join us very soon. We are just expecting the line to be coming. The topic was actually the use of medical management, and such a wonderful presentation. Dr. Lee has made it in a very simplified manner how you can go ahead and treat. And we would like to take some few questions. Madam, before that, I would
Yes.
request you to please comment on both the lectures for 5 minutes, and then we'll
Right.
go to the question answer session till the time Dr. Narendra
Right.
Malhotra will join us.
Thank you,
Thank
Dr.
you.
Niranjan. It was a very lucid and impressive lecture by Dr. Lee on HIFU. So what I just want to take home messages would be, right, HIFU, like its name says, it is highly focused. So it has to be very precisely managed. Otherwise, the temperature which goes between 59 degrees to 83 degrees centigrade, we need to be very careful about sparing the surrounding tissues. So the two main actions of HIFU, like Dr. Lee said, is the coaptation leading to thermal necrosis and cavitation leading to apoptosis. So the selection of cases is very, very important, Dr. Niranjan. So what, according to NICE, what is important is symptomatic. Dr. Lee very clearly and very impressively showed a photograph where the fibroid has been expelled. So we have to remember that the size decreases only by 40%. So if you're treating the report or treating the ultrasound picture, you might not see the exact difference, whereas the symptoms would be definitely improved. And we also have to remember that a fibroid should not be more than 12 centimeters in size, and it has to be less than 5 numbers. And we have to be where no pressure effects. These are the few things which we have to remember. And also the limitations which has been told already to us is that we have to do one fibroid at a time, and there is no tissue biopsy. So we are always worried about the sarcoma. So when we know there is no tissue for biopsy, we have to look at the other factors like age, LDH, and MRI, where there is no necrosis. If there is already necrosis, HIFU is not going to help us at all, because if it's only symptomatic, we have to look at that, and the ultrasound or the MRI shows no necrosis. If there is a lot of necrosis, these are not the ideal candidates for this question, for this procedure. So, and Dr. Lee also suggested that there are studies going on about the DIE, that is deep infiltrating endometriosis. So I'm sure waiting for the future about use of transrectal utilization of it in that DIE, especially involving the rectum and the sigmoid junction, and also for vulval dystrophies. And I know that most of the patients, when asked, they would always opt for a non-surgical option. And the best part of the HIFU is that we are dealing with it. So when gynecologists treat it, and we are happy to deal with our side effects and the complications, rather than the procedure being done by a radiologist and the patient come to us with bleeding and the fibroids coming out. So I think as far as HIFU is concerned, all the gynecologists who are trained in ultrasound should be training themselves, get trained, and be ready to take care of the non-surgical treatment. And the next lecture, which has actually been started very well by Dr. Narendra Malhotra about the medical management, I'm sure will be going ahead with a better way. I think what we have to understand about medical, like I already said, is that any surgical option, patient would always want to try a medical option before they think it is necessary to go for surgery. They want to avoid everything. And now the pathophysiology has been evolving, and we now know it has nothing to do with estrogen, and it is something to do with the progesterone pathway. It is logical for us to think that any medicine will work, which will work with progesterone modulation, receptor modulation will work wonders. So that's where, of all the medical management, the two medicines which have come forward as the medical management, which has really come forward, would be, one is SPRMs, that is ulipristils and all the anacepristils and all that. So second one will be aromatase inhibitors. That would be like when we start using letrozole before giving the surgery, especially in hysteroscopic myomectomy. I think Dr. Narendra is coming online, so we will go ahead with his lecture.
Oh, wonderful. Welcome, Dr. Narendra Malhotra.
Yeah, I'm very sorry. The power just got cut and I had not put it on the backup. So I'm very sorry about that. Okay, so we were at the medical treatment on what antiprogesterone. So antiprogesterone we have talked about, mifepristone, but not used very widely. Danazol, as I told you, because of the masculinizing side effects, absolutely no to this drug, and we are not going to use any danazol now. GnRH agonist in depot preparations, goserelin, leuprolin, brusferlin, naproxen, all of them can be used, but the disadvantage about GnRH agonist is that they will cause menopausal symptoms and bone marrow depression. Antagonists, cetrorelix or ganirelix, the depot preparations we are waiting. As soon as we get the prostate cancers, and also for us it might be helpful. The advantages of analogs are that the menorrhagia improves, and there is improvement of anemia, there is relief of pressure symptom, the fibroid size reduces by 50% if it used for 6 months, there is reduction of the vascularity of the tumor, reduction of the blood loss during myomectomy, and it makes the surgery easy. The only problem is the planes are lost. So sometimes the dissection becomes very difficult. So the myoma enucleation becomes very difficult. Plus, it will give you all the menopausal symptoms. Plus, for 6 months, the cost is a lot. And then BMD, bone loss, and all that is there. What about NSAIDs? Prostaglandin synthetase inhibitors only to relieve pain, and they cannot improve menorrhagia due to fibroids. So they are given with antifibrinolytic, with combination with mefenamic acid. Yes, maybe during the menstrual period, the bleeding is a little bit reduced and the pain is reduced. LNG, if the fibroid size is less than 14 weeks, so let's say 12 weeks, then yes, otherwise we will need to do another treatment. So all these medical therapies have their own drawbacks. OCPs have drawbacks, LNG has drawbacks, agonist depots have drawbacks, and we cannot have them used very frequently. So the demerits of these medical treatment which we had, they are expensive for long term. The fibroid starts growing immediately when you stop it. There is difficulty in establishing a surgical plane between the fibroid and the tissue when you give them analogs, and menopausal signs and symptoms. So the newer way of pathology, as Dr. Manjula was also discussing during the breakdown time, is that progesterone plays a vital role in promoting uterine fibroid. And we need to target these receptors which are the progesterone, which are fibroids, which are progesterone sensitive fibroids. So here you have the estrogen molecule and the progesterone molecule. The estrogen receptor binding was twice as the progesterone receptor binding, was 3 times higher in the fibroid in the myometrium. So you see here, it's the progesterone which now is thought to play a big role, while both of them have an effect on the binding in the fibroid. So progesterone has a dual action on fibroid growth. First, it will stimulate the growth by upregulating the epidermal growth factors, which is EGF, and BCL2. BCL lymphoma is a key protein for inhibition of apoptosis. So that will be affected. Then progesterone down regulates the tumor necrosing factor alpha TNF expression. So if we remember that, then we will know that if we have something which will selectively modulate these progesterone receptors, that will form an ideal therapy. So the role of progesterone in promoting fibroid growth is known, and it has stimulated a lot of interest in modulating the progesterone pathway, and thus sperms, that is selective progesterone receptor modulators, are now coming out as an innovative therapy in the uterine fibroid management. So what are the selective progesterone receptor modulators, or some of them are called as only progesterone receptor modulators, like mifepristone? It is ulipristal acetate, aspronil, and telapristone acetate, which have been investigated. Now they decrease the size, they reduce the bleeding, they can let women have fertility, so enjoy childbirth after the therapy, natural pregnancies, and all that. So they have a lot of advantage. So let's see how they do it. Now sperms are agonists to the PR, and they are antagonists to the progesterone receptor. So act on both, dual. And then they will cause an RNA pol 2 transcription activation, and they will block, this will block the transcription activation, and the PR ligands displaying the selective agonist-antagonist mixed activity of the target cells. So that will take care of the growth of the fibroid. So asprinil was used with great success, as a progesterone receptor modulator, and it does not cause endometrial hyperplasia. But then more research went to uleprostol. And let's see what uleprostol is all about. So we have the other molecule, which is uleprostol acetate. It causes reversal blockage of the progesterone receptors, reversible. So once you stop, the receptors start functioning. Binds with the progesterone receptors, but not with the estrogen. So no hypoestrogenic condition, no menopausal bone loss, all that. No affinity to the mineralocorticoids receptor, so it does not affect the whole body. And the action is only on the fibroid cells and not on the normal myometrial cells. That's the beauty. It has an approval of almost everything. It went into dispute with an RCOG statement saying that it causes 8 cases in that study caused liver damage. Yes, that caution has to be taken. Patient has to have an LFT before. Only those without a deranged liver function should be put on uleprostol acetate therapy. How does it work? It has a potent anti-progesterone action directly on the fibroid. So it shows a apoptotic action, decreasing the BCL2, which I just showed you, so decreases the size and the volume of the fibroid. It acts on the hypothalamic pituitary ovarian axis, decreases LH and FSH, so inhibits ovulation. This drug is also used as an emergency contraceptive pill in the dose of 30. Here we are talking in the dose of 5. So on the endometrium, it shows an anti-proliferative action, so it induces amenorrhea. So it's got a threefold action. And the clinical benefits would be, it will correct the anemia, it will reduce the intraoperative blood loss after uleprostol therapy, it will reduce the operative time, it will reduce the need of blood transfusion, and instead of hysterectomy, myomectomy will work here, and the patients will be uterine conservation surgery can be done. So it reduces the fibroid volume, corrects anemia, and allows a less invasive surgery to be performed. We have the MIA, how it was there, and the pre-MIA study outcomes given before surgery, 12 months following treatment. You see 39 patients who underwent surgical procedure during the 12 months, and 42 patients in this study did not need, they all were for surgery, and they were put on the pre-operative uleprostol, and 42% did not need the surgery because they got improved. So clinical benefits of uleprostol introduced before scheduled surgery are now absolutely proven. Also, the advantage is that it does not disturb the surgical planes. So laparoscopic shelling out of the fibroid becomes easier as it was, not like GnRH analogs where the planes are lost. Who says so? 2017, actually, Venus 2 study and Venus 2 studies were presented. US-based phase 3 studies on uleprostol acetate for treatment of symptomatic and for treatment of symptomatic fibroids in a dose of 5, and later in the phase 3 studies in the dose of 10 also. And it said that numerically greater response in efficacy was observed with both the 5 and the 10. And the quality of life with uleprostol acetate treatment of symptomatic uterine fibroids, the quality of life improves much more. The score, UFS QOL's quality of life subscale score improves, and the woman leads a normal life if they were put with symptomatic fibroids. Uleprostol acetate treatment with symptomatic uterine fibroids, the Venus 2 subgroup, is not related to race and BMI. So all women were responding same. So what would be our indication and dose? Our indication and dose would be symptomatic management of uterine fibroids, pre-operative to reduce 1 tablet 5 milligram to be started in the first week of menstrual cycle, preferably day 4 of the menses or day 5, and given continuously for 3 months, and then stopped for a month and restarted for the next cycle, repeat course from day 4 again. And first course and second course, and 4 courses like this. So 12 weeks therapy with a 1 month break in between each therapy. The side effects were hot flushes and headaches, but very less in very, very few women. The contraindication, of course, pregnancy, genital bleeding of unknown origin, hypersensitivity due to any drug, uterine, cervical, ovarian, breast cancers. Special warnings if the patient is on contraception, renally impaired, hepatic impairment was the biggest warning. So LFT has to be done, and every 3 months LFT has to be monitored. And if you see a deranged LFT, the drug has to be stopped. Asthmatic patient, endometrial changes, concomitant other drugs being used, and bleeding pattern of the patient should be kept in mind. Now we had this great PEARL study. PEARL is P, that is the drug, PGL4001, which is uleprostol acetate. E is efficacy, A is assessment, R is reduction of symptoms due to uterine, L is leiomyoma. And PEARL 1, PEARL 2, PEARL 3, PEARL 4, in phase 3, the conclusions, as you can see, 13 weeks effectively controlled bleeding. Both 5 and 10 milligrams, very, very good, better than leuprolide acetate. Repeated 3-month courses of oral UPA 10 milligram, very effective in controlling bleeding and pain. QOL, much better, quality of life, much better. And PEARL 4, efficacy and safety of repeated use of uleprostol in uterine. So repeated 12-week courses with oral 5 or 10, controls it, and is safe and improves the quality of life in all the symptoms. And these were done as efficacy analysis. I'm not going to go into these details. They were done as time to persistent amenorrhea. They were done as safety analysis, and it was pretty safe as a conclusion. And the endpoints was evaluated as efficacy endpoints and safety endpoints. So serum estradiol levels, proportion of patients suffering hot flushes, lab assessment, bone markers, endometrial thickness, ovary. Those were the safety endpoints which were taken in this. PEARL 2 studies compared, as I showed you there, compared with leuprolide acetate. And once a day, oral 5, once a day 10, with 3.75 leuprolide acetate once a month, and then surgery. So it was shown that the uleprostol patients fared better. And this is what the study showed, the long-term effects of treatment of uterine fibroids with uleprostol acetate. First 3 months, second 3 months, third 3 months, fourth 3 months. Enrolled premenopausal women with at least one fibroid, more than 3, and none of them more than 10. With more than 10, surgery is better. It was double-blinded and compared with NITA, that is norethitron acetate, 10 milligrams twice or thrice a day, and the red spots are the menses bleeding. And there the efficacy was studied. And it was seen that it was safe. Ovarian problems were not there, hematology was not there, estrogen levels were not there, no cases of endometrial hyperplasia. 10 days treatment with norethitron did not affect significantly the treatment outcome. So, and then it was compared with the first series of 18 pregnancies after uleprostol treatment for uterine fibroids. So these patients were followed up and they got pregnant on their own, and it was seen that the fibroid did not increase in size during the pregnancy. So that showed that there was a long-term effect of uleprostol even after stopping the drug, even when the patient got pregnant, on the effect of the fibroid. So no regrowths of fibroids occurred during the pregnancy in this study, reported infertile sterile. Also, this the endpoint analysis with volume, cessation of bleeding, hemoglobin recurrence, it showed that 26 patients out of the 56 did not require surgery at all. They did not require. The long-term treatment of uterine fibroids with uleprostol acetate, again, a woman with heavy menstrual bleeding, all biopsies showed benign reversible changes, volume reduction 50%, amenorrhea 79% after the first course. So it works in the first month. Then we had the NICE guidelines for less than 3 and more than 3 centimeter size fibroid. LNG, antifibrinolytic, NSAIDs, or progesterones. More than 3, then you need to give 12-week course of uleprostol. That would work much better if the fibroid is bigger. So the NICE recommendation of more than 3 and less than 3, uleprostol and surgery if it is big, and the others can be tried if the fibroid is less. So, ladies and gentlemen, to conclude, here is an option in the form of an oral capsule for the management of symptomatic fibroids. which will preserve the uterus, which will improve the fertility, which will improve the quality of life, which can be used prior to surgery for improving your surgical outcomes, which can be used safely in perimenopausal women, in women with relapse after myomectomies, to control the symptoms, to decrease the size of the fibroid, to change the course of our operation from a hysterectomy to myomectomy, and also laparoscopy it does not affect because of the planes, and it is well tolerated. Of course, a lot of other drugs, herbal drugs in India, China are available, and Hong Kong, but they are not scientific, they are not being tried, but they are available online for anything. Thank you very much for inviting me here and letting me express some of my views on the medical management of fibroids. Thank you very much.
Thank you, sir. Thank you so much. It was a wonderful presentation. Dr. Narendra Malhotra, you covered the use of ulipristol, use of mifepristone, and the new kid on the block, and also explained regarding the Pearl study and Pearl trial 3, 4, and obviously it was a wonderful presentation where you have given the overview of how to go about. Now we have got more than 200 questions, but before I go to 200 questions, I request Dr. Manjula to please continue with your comments. Sir was not there, and obviously you talked about Dr. Lee. So the mic is yours, madam.
Thank you, Dr. Niranjan. I just have to add 3 points to what Dr. Narendra has very well clearly told us. So first is about pre-operative. When we are doing it, we have to give it for 1 cycle before the surgery. And when it is therapeutic, it is 4 cycles. So that is 1 point everybody has to remember. The second thing is, yes, during the surgery, your planes will be clear. But what we have to understand, if we end up doing myomectomy, is there is lysis of the center of the fibroid. So when we are removing the fibroid, it will become very difficult for us if you are using morcellation. So in-bag morcellation is something which you have to practice if you are doing the surgery after the ulipristol usage. And a third point which I just wanted to add is that there is something called PAEC, that is progesterone-associated endometrial changes. We have to know that because in India, people have started using the ulipristol a lot. You don't see it usually out of India, but here they're using quite a bit. So there is something called PAEC, that endometrial changes you get with all SERMs and SPRMs also, which will look as a thickened endometrial lining and the ultrasound associated with amenorrhea. So don't get worried. It is only temporary thing and it will shed. Otherwise, I think I'm very sure all the audience of 5,600, whoever has come online, have learned a lot about the non-surgical treatments of the fibroid.
Yeah, thank you, madam. Now we have got questions which are coming. I think we will go back to Dr. Narendra Malhotra before we ask questions to Dr. Lee. Sir, now there are certain issues regarding this medical management. So we would like to, obviously you have explained us in the presentation, but there are questions which have been asked that what is the criteria for using this medical line of treatment? I mean, most of us are comfortable with laparoscopic surgery or hysteroscopic surgery, and we have been totally surgically oriented. We are not that much proponent as compared to any other country, but now this is the new kid on the block which is also there, and obviously I will go to HIFU, Dr. Lee, but I want some comments from you that how would you change this perspective?
So as in the beginning I said, in India gynecologists are knife happy. Even a 2 centimeter fibroid, they will go ahead and remove it surgically. Yes. So that is our major problem. If one gynec does not remove, the other will remove, or even a general surgeon or a laparoscopic, which is a major, and they'll do a hysterectomy for a 2 centimeter fibroid because they feel that the women will not come for follow-up and things like that. So we have to change that attitude. We have a medical treatment which has long-term effects, and the treatment, after stopping the treatment, the effect continues. There are some set which are not operable. There it is clear, very large fibroids, very clear, surgery is required. It is the small fibroids, less than 3 centimeters, which should be tried medically first, and then family complete. And as I clearly said, medical treatment will not make the fibroids vanish. So it's not a complete treatment of fibroids. You are only giving symptomatic relief and you are reducing it. Family complete, everything complete. She gets the symptoms. One more repeat therapy, one more course. She gets it repeatedly again, do surgery. So that is how we should follow.
Thank you, sir, for your wonderful scientific comments which are there. I'm sure the approach towards fibroid will change to a certain extent. Now I come back to Dr. Lee. Hello, Dr. Lee. It was a wonderful presentation. We have got more than 200 questions which have been asked here. Obviously, I'm not going to bombard with so many questions to you, but I'm going to filter them. And I would also like to tell all of you that there are now 6,268 doctors who are logged. I think we have broken all the history of records of live webinar with such esteemed, the speakers and Manjula madam being there with us. People are just crazy about academics, and it's not only that they are just more interested in doing something else. So we come back to question, Dr. Lee. Now, HIFU is something which is very new in India, and we want to get those machines in India. Obviously, it will take some time, but we want the answer from you is to what extent you can go and use this HIFU up till what centimeter of size of fibroid, or beyond it we cannot use it, or we should not use it.
Okay, my first comment on whether the machine is available in India or not. Yes, I think I've met some companies marketing the machines, and this is a company from India, and actually met them in Hong Kong. But then I was not really interested because it is a MRI guided HIFU. In other words, I really have to depend on MRI whenever I perform HIFU. Secondly, your second question is, what's the size of the fibroid one can tackle? Really, for a start, I really hope that I have the easy ones like 3 to 5 centimeters with some mild complaints or symptoms like bleeding or just pain. But the moment you start on a case of HIFU for the chosen few that you have been watching them, the rest will come because of media, word of mouth. And the funny thing is, ironically, the difficult cases started coming. In other words, you have a lot of patients who are being cared for by your other colleagues. And the typical example is 3 cm weight, 4 centimeters weight. And then when it becomes 7 to 8 centimeters, I think you better remove your whole uterus. This became a shocker to many of the ladies. So what is the biggest I have done? The youngest I've done, 22 years old. The biggest I've done is a fibroid that has reached the belly button. Again, whenever I counsel patients for HIFU, I always tell them, look, there's no promise the whole fibroid will disappear. The main message I give to the patients is this: may not completely go away, because it will never completely go away. There will always be fibrous tissue grouped together, left behind. So the bigger it is, you take a longer time to do. You really test your patients. Remember one of the point I said is patients are very important. And I think dealing with fibroids with HIFU should never be a Guinness Book of Records, a challenge to see who has done bigger, as in laparotomy or laparoscopic surgery. So do the simple ones first until you're competent with not just the treatment process, the science of it, how you manage the machines, how you counsel your patients, and always tell them that it may take anything from 1 hour to 4 hours, because you actually attack the fibroid by millimeters to a millimeter. So on the day when you are tired just after doing a delivery in the middle of the night, I don't think you should do the big ones. However, as doctors, you know, we can't choose. Patients just come to your doorstep. Even now with the COVID virus on, and we are not supposed to see non-essential patients, the bleeding ones will come, the painful ones will come, and we just have to handle them. So the biggest I've done so far is up to the belly buttons, but there's one that is higher than the belly button, which I am going to stop her bleeding first with GnRH. Her hemoglobin is down. So that gives me time to say that, look, whatever it is, whether it's surgery or non-surgery, make sure your hemoglobin is up first before we do GnRH. And as you know, when you give GnRH, the first 10 days, there's a reactionary bleeding. And that's where I fear that if you're coming to see me with a hemoglobin of 6 and then you have the reactionary bleeding on day 10, it may drop to day HB of 4 or 5, that's good for you. So I'm very careful about this, and I think all my colleagues have the same, share the same sentiments. So I wish the typical fibroid that the first paper written in Chongqing, they've been doing on just 5 to 6 centimeters first. From the start, do the easy ones first. When you have to do the difficult ones, you should get somebody more experienced to sit next to you. Okay, that's my take on HIFU.
Dr. Narendra Malhotra. After that, Dr. Manjula, please give your comments on Dr. Lee's answer.
I totally agree. Very large fibroids should not be attempted for medical treatment and even HIFU unless the patient is cannot have surgery or the hemoglobin is very low. Absolutely, yes. See, if we have a modality, it does not mean that we should know how to draw lines and where to draw lines.
Yeah, and my take is all the T's. First is a technique. You should master your technique. Second, whenever a technology comes, you should get proper training. Then train your team, and finally your temperament. Like Dr. D said, after whole work is over, and then you jump onto it and do it, and your temperament, you can go for a fuse. So I think have your the right time when you're learning early in the morning. You train yourself, learn your technology, and then go ahead. But nice guideline says 12 centimeter. Do not cross it initially. So I think that's fine.
So I think 12 centimeter would be the cutoff point where anything about 12 centimeter you can surely go ahead and not do this. But obviously Dr. Lee has got more experience. He has done more than 1,000 cases and he has been practicing this for so many years, 2 decades. So and nowadays, yeah, sorry, madam, please go ahead.
No. Perfect, Navin.
Yeah. So wonderful, Dr. Manjula and Narendra Malhotra sir also is acknowledging the technology, training, team and temperament, and we all agree that this is very important. And I would like to share here that I got just before the lockdown 2 ladies. They were very young, about 25, 23 years. They were unmarried and they had come with fiancé. Obviously, they were not married, and she had fibroid about 8 to 10 centimeter. She had a lot of concern about laparoscopic removal of that fibroid. She wanted more of medical management. She asked that I have been referred to you, sir, that we have got this ultrasound department and whether we do. So yes, we have one machine which is MRI actually, and they are doing that. So I had to counsel her, explain her, and then we had to refer her to undergo that ultrasound treatment of high focused modality for removing. And after 3 months, she was very happy and she got married. So I think that is also very important. Young women, young girls are not that much comfortable of doing a laparoscopic surgery. Maybe it might be different when you are about 35 or 40 and obviously perimenopausal. What do you feel, Dr. Narendra and Dr. Angani?
Yes. Narendra, you're taking it first, or?
No, I think you take this.
Yeah, my take is actually, like I said, no medical management or even any non-surgical will not make the fibroid disappear. We should be very, very clear in explaining to them. So perimenopausal patients who go for this master health checkups, and then they see this ultrasound, which is showing 3 centimeters, 4 centimeters, and they're worried about it. Those are the patients who can try this. That is first thing. And pre-operative is another thing which you can always say where we can avoid surgeries, or we might end up but having a better outcomes of the surgery. And like you said, pre-married or whatever, young girls who are scared. So it is always the patient who comes as the first choice who have to take, but they have to be symptomatic for them to be happy. Otherwise, the ultrasound again after 3 months shows only 1 centimeter decrease, 2 centimeters decrease, they're never going to be happy. So symptomatic, and your technology you have mastered it, and you're going to, they have the time to wait for almost 1 year. So it is not just after 3 months, 4 months, the size is going to disappear. So it will take 8 months to 9 months to decrease some notable size and the symptoms to improve. So patient who is cooperative, who is symptomatic, and who is going to be a very compliant patient, I think I would choose those patients over anybody who is in a hurry to get anything done.
Thank you,
So
Dr.
that is what my algorithm had shown. That is what my algorithm has shown.
Yes,
Take the patient's age, her desire, her fertility, her age, and her childbearing and her family complete. Keep that in mind. You divide it into asymptomatic, symptomatic, because they're picked up routinely in some routine ultrasound, totally asymptomatic, 3 centimeters, nothing to be done, yearly follow-up. 1 year, not every month an ultrasound which says the fibroid is not vanishing, and then someone will do an operative treatment on her. Only symptomatic, then you offer them medical treatment or surgical treatment depending on what their situation is.
Dr. Narendra, there is one question for you. How many months can we give ulipristol, and what is the duration of the dose for this medical management in case of fibroid, which is approximately 5 centimeter in size? This question has come from Philippines.
So 5 milligrams a day, starting day 4 or 5 of the menstrual period for 3 months, 1 menstrual cycle break, then another 3 months, 1 menstrual cycle break, another 3 months, and 1 menstrual cycle break, another 3 months. 4 courses of 3 months each is, so 12 weeks is your complete dose schedule for 5 or 10. The 5 or 10, the results are same, and monitor LFT every 3 months.
Wonderfully explained. I think Dr. Anagani is also acknowledging the same sequence of treatment to be given to our patients, and it has been wonderfully explained by you. Now I come back to Dr. Lee. There are many questions to you, sir, because now this has opened a new window pan-India and in SAARC countries, which your lecture has gone about more than 6,200 members being seen. Now, Professor Lee, whether we should give any medical management before we start the sittings of high focus ultrasound, this question is being there by Dr. Arun Dutt from Thailand.
Okay, sure. Unfortunately, ulipristal acetate has been withdrawn from Singapore because of some issues with Europe, and also because of the worry about liver function. So I can't comment on ulipristal acetate now because it's been withdrawn from Singapore. Now, medical management will be centered upon when the patient is going for HIFU. Assuming we have already excluded patients who refuse or patients who refused surgery, young, still not married, wants to avoid a scar in the uterus, that group of patients, then when will I do HIFU? It's actually very practical. By the way, I'm in private practice for the past 33 years. So my outlook or viewpoint in managing patients will deviate from, all the professors or the academia. I tend to take a more practical clinical approach as a private practitioner. So when the patient comes and she wants HIFU, really just the other day, patient comes with HIFU, but the uterus is big, hemoglobin is down, then I have to think of something to use to bring the hemoglobin up. It's either, if she's in a hurry, blood transfusion, which I normally don't advise, or the best is give GnRH for 3 months. That serves two purposes. One is it shrinks the fibroid, so that when I do, it's not the 12 centimeter fibroid, hopefully it's a 6 centimeters fibroid, and at the same time, it brings up the hemoglobin. Now, for patients who are not so big, let's say it's 5 to 6 centimeters, and has to do it fast, and you will understand, some of us, what we do is guided by a lot of factors, social, economical. Sometimes I think it's the insurance company have a lot to say in this, and of course, the bosses, which is going to give them the leave to make themselves available for the procedure. So if somebody comes to me 6 cm, 5 cm, and wants to do it in a hurry, then I would say, look, the fastest to me still, you people don't laugh, is to intramuscular progesterone, not testosterone, to stop the bleeding first. Until the bleeding is stopped, then I will bring her to for a trial of HIFU machine. In other words, she'll lie down on the machine, and I'll tell her, with this fibroid, I can safely achieve a 90% success rate, or I just turned away one patient whereby the fibroid is cervical, very posterior cervical, which I know I cannot get the ultrasound waves right to where it is supposed to be. I just turned her away and said, okay, lady, I think it's best we go back to laparoscopy or laparoscopy to remove the fibroid. On other occasions whereby the patient said, it's okay, I can wait because I have work to do and on leave in 3 months' time, then I would try my best to give GnRH to bring the fibroid. So very much really depends on the presenting symptoms, the circumstances around the case, when I'll do the fibroid. Now, I can't say I will give GnRH to all the fibroids, because if I do a trial now, today, and she's fit for HIFU, and I give GnRH 3 months' time, the size of the fibroid has changed. So the coordinates in which I'm going to fire at the fibroid would have changed. So I normally do the fibroid or the trial nearer to the date whereby I do my HIFU. Now, when it comes to adenomyosis, again, if I can bring up the hemoglobin, patient is suitable for HIFU, I will do the HIFU first. And I always tell them, and look at it, is it a diffuse adenomyosis, or is it localized adenomyosis or adenomyoma? The response is different. Adenomyoma responds to HIFU much better than diffuse adenomyosis. So when it's diffuse adenomyosis, again, I have to counsel the patient that the success rate may be just 50% or 60%. If you're willing to go through it, then I'll go through it. And very often I tell them that you may need a second treatment. It's up to the patient. And really, of the 88 patients I've done, I didn't do 1,000 patients. My trainer next to me has done 1,000. I've done 88 personal cases. In 1 year, I have to repeat a HIFU for adenomyosis. And in 1 year, a second adenomyosis failed because the pain came back because she's still young, and I have to do a surgery. So it's very difficult for me to have a flow chart in a very simplistic way. But I think this, as you go along, you will probably have your own flow chart according to your own practice, the nature of your practice. I look at may I just comment even on classification of fibroids? Everybody will use the classification of fibroids according to the FIGO classification. But when you do HIFU, you look at a different way of classification, because the pedunculated fibroids are probably not amenable to HIFU, because in HIFU, when the fibroid dies, you need the normal fine tissue and blood vessels to bring the debris away. It's like when you have a knot on the forehead, there's a hematoma, it will go away. So imagine the fibroid needs a good area or blood supply for it to be resolved into the uterine complex for it to slowly shrink. So when it comes to pedunculated fibroid, I would say this is not suitable. Now, when it comes to submucous fibroids, I will give the patient a choice whether I have this, my own principle, less than 3 centimeters submucous, type 0, type 1, hysteroscopic resection. Type 2, and it is big, I would say you can string it first with GnRH, whatever means you have, or I would offer HIFU. Reason is the classification of looking at HIFU, I will classify as 1, pedunculated, not suitable. two suitable or the intramurals, and then subdivide into anterior and posterior, and then the submucous, whereby you either can do HIFU if it's type 2, and the main bulk of the submucus is still within the uterine cavity. But if it's going to be 3 centimeters, type 0, type 1, I think that's the easiest to resect. So my limited experience tells me that the classification of fibroids in relation to HIFU management will probably be different from the FIGO management. And that's all my comment.
Thank you, Dr. Lee. It was a wonderful explanation about the classification and how to go about to do a HIFU and the patient selection, which you have properly told and explained to all of us. There are many questions which have been lined. I would like to go back to Dr. Narendra Malhotra. There is a question from Dr. Sarita Anand that she is a 54-year-old woman, 2 children, and has got multiple fibroids on USG with endometrial thickness of 12 millimeters. She has been treated with ulipristal for 4 months. And LBC negative HPE of the endometrium is secretory. She is asymptomatic now for past 4 months, sir. Please suggest measures to follow up.
So Dr. Manjura has already answered that. You just wait, follow up every year. The endometrial thickness is a false here, as she explained so beautifully. It's nothing to worry. The endometrial hyperplasia does not occur with ulipristal. So she's got treated 4 months. Actually, it should have been 3 months, 1 month break, 3 months, and 1 month break. So either you can continue your therapy for 3 more cycles. If she's asymptomatic, you just wait, follow up, and by yearly ultrasound and pap smear. That's all.
Dr. Anagani, you would like to share your experiences about HIFU and your medical line of treatment?
Rather than HIFU, way back in 1998, I think we did our first uterine artery embolization in Care Hospital when we were doing, and we were not very happy. There are 2 reasons why I was not happy. One is we had to depend on a machine. Here it is MRI. There we were utilizing a cath lab. So we are always the second citizens there. So if we are doing MRI or anything, somebody else wants to use it, we have to go and get it done in the evening, 7 o'clock, 8 o'clock or something like that. And then even because the patient is there, you're going to be there. One, being a private doctor, we all want money and we are not going to get it. The second is the complications. When the patients start having the extrusion of the fibroid, we did have issues. So that's the one reason which we were not using. And in the middle, in India, when HIFU just entered and when we had Dr. Rakesh Sinha doing it, I had spoken to him about it. So we did have HIFU in Mumbai, Dr. Rakesh Sinha. He was not very happy about it because HIFU is something which we were not doing it. But in again, 2011 and 12, when Insightec came to India, and we did have in Apollo, Philips and all, we had lots of patients. But again, the same thing in India is all of us are busy. We are not going to only one subject of doing only one thing. And when we have time, the machine is not free. So, and then dealing with the complications. So I think these are the practical points. But now, as the younger generation is coming up and they're very clear about, they do not want to do the emergencies in the middle of night, less obstetrics, want to stick to fertility or something like that. So ultrasound side, if somebody is going and they want to pick this up, this would be a very good modality, especially like Dr. Lee said, for adenomyosis, adenomyoma, where we can only think of Mirena and hysterectomy as a better alternative than any other thing. HIFU will wonderfully work for adenomyosis younger patient, pre-IVF patients, and in DIE. And I'm actually waiting for people to do a lot of studies of HIFU on vulval dystrophies rather than going for all these lasers and all that.
Thank you, Dr. Anandani. Now the next question is to Dr. Narendra. Dr. Rajni Bala is telling about a case. She's a married lady, 6 years, having a 7 centimeters fibroid. This fibroid is intramural and she has never conceived, not ready for a surgery. What to be done with no symptoms?
So this patient qualifies for expectant management or medical management. Now, expectant management is that if everything else for infertility is working all right, the tubes, ovulation, husband semen parameters, you could give her 3-4 months or 6 months of time intercourse with mild stimulation or not, or you give her uliprostol for a course of uliprostol for 12 weeks, 12 courses, 4 courses, 3 months each, so 1 year, and then ask her to conceive if she's not ready for surgery. So by that time, 7 centimeters will become almost about 3.5, and then conception chances might improve. So uliprostol, 4 courses, and then conception.
So now very interesting question again to you, very tricky question. This question is from Dr. Asha Jain, and she has said that myoma during pregnancy which becomes symptomatic and it is more than 4 centimeter. How would we manage this case? Dr. Narendra Malhotra, sir.
Tender loving care.
No uliprostol to be given during pregnancy.
Pregnancy is contraindicated.
Yes.
It's
So Dr.
contraindicated.
Asha Jain, we do not give uliprostol in pregnancy, only tender love care. And Dr. Narendra Malhotra.
Mild uterine relaxants, mild painkillers. That's all. I mean, don't give her overdose her with progesterone. This might start increasing if you give her more progesterone also. So don't put her on micronized progesterone or vaginal progesterone. Please don't.
Okay. Now, Doctor,
can I?
Madam, yes, Dr. Mandla, what would you do?
Now, there are two things here. One, I would agree with you, tender loving care. The second point about progesterone is that sometimes what happens is this itself can irritate the uterus to go for the patient to go into preterm labor. So that time we should be watching, and if necessary, please do give progesterone, but temporarily. Cannot be overdosing it for a long time. That is
so only for prevention of preterm labor, not for.
Yes. And the second point is there are times when patients, if it is too big a size of a fibroid and it causes respiratory distress, especially when the twins are there, to continue the pregnancy, there are times when we have done antepartum myomectomy, antenatal myomectomy, whatever. But otherwise, if she ends up with cesarean myomectomy would be better in this case.
So my experience with antepartum myomectomy is over 10 centimeters.
Yes.
You know that I've managed
respiratory distress, it should be that thing. Yes.
So if it is very big, and yes, we have done 2 or 3 of them over 10 centimeters.
Dr. Lee, I'm coming back to you again. This is from Dr. Suhasini. She says that the patient is 54-year-old woman. She did a HIFU. Can you please elaborate which hormonal profile you would do after 9 months of completion of HIFU on this woman? Thank you, sir.
Okay, this case is very interesting because she was a patient that was followed up by another colleague, and from a small fibroid became a big fibroid. And, you know, you can reason with the patient what are all the reasons to remove the uterus, bleeding, more than completed family, more than 55 years. I've said before, this 54-year-old woman now behaves like a 34-year-old or dresses like a 34-year-old. So no matter how much you can reason with them, she just wanted her way. And of course, I want to know for myself whether you should just wait for menopause to come. But she's very adamant of doing something because she said, look, my fibroid is growing and my other doctor wants to do a hysterectomy. So what I did was I told her, look, I'll try, but I don't promise. Now, 9 months later, and why not 6 months or 9 months is because of their insurance process, whereby they only allow MRI to be done after a certain number of months. So 9 months later, I saw her, and at the same time, for my own sake, I want to know whether her hormone profile is the same as 9 months ago. So that's why I do the hormone profile. So it's not a regulation that I'll do a hormone profile. Just like it's not like a regulation that you do liver function tests when you're on ulipristal acetate. So it was my own self-interest that I did it. So after that, the fibroid shrinks, but a fibroid will never shrink to 0 or disappear. You either shrink to a size whereby it calcifies, like most of the menopausal women, or I'll explain to them It's like putting sugar cane through the rollers, whether you roll it 10 times or 100 times, the residue, the fibers are still there. So your fibroids was there, but although small, and we probably cannot pick it up from an ultrasound, but if you do MRI, you can pick it up. So, well, the most end of story is the patient is very happy with the result, and she's just willing to wait for her own natural menopause to set in. That's the story of that patient. But there will be a lot of patients like her who get very angry. Doctors ask to observe, and the fibroids keep going. And this is something my younger colleagues, I said, if you ask a patient to observe a fibroid, say 4 centimeters, and if the fibroid grows and you still say observe again, be very careful when you say observe. Are you observing that hoping by next year it's getting smaller, or you are observing to wait for it to get worse with the complication? And then, you know, there are a lot of lawyers around waiting behind. So we have to be very careful when we say observe, and you must have the confidence to say that if you observe that menopause will come, the fibroid will shrink naturally. That is my advice to them now. And I just saw on the screen, somebody asked a question about what becomes if you have a HIFU and you did it for a sarcoma. Now, when HIFU first started, they actually did it for osteosarcoma for 2 patients, young patients. One was very successful. Patient got married, have children. The other patient was not so successful because after 2 years, the other patient died of some other illnesses. Now, in the brain, we used HIFU. In advanced liver cancer and pancreatic cancers, we use HIFU for palliation. So in the event you have done a HIFU on a fibroid that turns out to be sarcoma, I think there's no harm done. The only complaint is, and which has happened in one of my friends from Korea, is the patient came and complained and said that, you know, if we picked it up earlier, maybe I could have done the surgery earlier. But there's no way to tell, because by treating the sarcoma, you may actually have done her a favor of reducing the sarcoma size, and which make it more amenable for surgery. If you draw collateral or conclusions from treatment of liver cancers, pancreatic cancers to shrink so that you get palliative relief, then I think if you've done unknowingly a sarcoma with HIFU, I don't think you have done a great harm to the patient. Now, we always argue since the modulation on the sarcoma started in US, that there's no good way of telling whether the uterine fibroid is a sarcoma or not. But lo and behold, there are a lot of HIFU practitioners from China, and one of them is Professor Zhang Lian. Whenever we have a questionable MRI, we'll show it to him. He'll be right 99.9% of the time, because he has seen so many MRIs. In fact, more than a lot of radiologists on just uterine tumors. So I would say, yes, with experience, we can recognize sarcomatous changes from MRI reports, as I think it's going to come.
Thank you. Dr. Lee, there are many questions. We have already answered them, about 3 to 4 questions together. So thank you so much. It was regarding finding out whether the patient has got sarcoma before starting the therapy. Now there is one more question from Dr. Rebecca Singson. Ulipristal has been recalled in some markets. She's from Philippines. Are you still recommending Ulipristal in your country? What is your take on this, Dr. Narendra Malhotra?
So Ulipristal had an issue with an RCOG warning 2 years back on that disturbance of the liver function. and 8 patients in that study landed up with severe liver damage. So if the liver function has to be done before starting and then monitoring, the other question from some doctor in Macau, as I could see, how we will monitor ulipristal 4 courses. Every 3 months when you, every course when you stop, 3 months, that non-ulipristal month, you do a LFT. So that is how we monitor. And if it is getting deranged, stop the drug.
I think you have touched a very relevant point to monitor LFT and try to see, and that is the best way of monitoring it in India. Presently, it is still continued. So we are giving it for the medical line of treatment. There are many questions which have been asked. There is one question in Nepal, sir. There is no ulipristal available. Which drug is best in absence of ulipristal? This is Dr. Ram Kumar Das for Dr. Malhotra.
Dr. Manjula will answer this.
Yeah, now my favorite drug, if she's married and she's having the children and no problem with intrauterine device, LNG-IUS is symptomatically better if she doesn't want oral ones. But otherwise, around perimenopausal age group, again, aromatase inhibitor is something which I would definitely choose over the thing. So, and otherwise, in the younger age group, it's only symptomatic, then OC pill. So you have to choose depending on the age of the patient, need of the patient, and then only decide.
I think Alembic should make ulipristal available in Nepal, and they will do in a period of time. Dr. Indira Rani, does patient have any febrile symptoms after HIFU of large fibroids? Dr. Lee.
Sorry, can you repeat the question again?
Fever. Does she get fever after HIFU?
Okay. Fever after HIFU usually is reactionary because you have killed the cells, you ablated them, just like in any surgery. Whether you remove the fibroid, you remove the hysterectomy, there's always a reactionary fever, which may not be due to infection. Yes, in some of my patients, they do have this febrile response, but they're very mild. They respond very well to paracetamol.
Yes.
Okay. There are many questions which are coming. Dr. Ela Gupta, in any asymptomatic fibroid, would we take for HIFU? If it is an asymptomatic fibroid, Dr. Lee, do we take for HIFU, and what is the size when treatment is essential? This is not there on the chat. This has been sent to me privately. Dr. Lee.
Okay, sure. Every good clinician will follow guidelines, and one of the guidelines you follow, NICE guideline, they say for HIFU is for symptomatic fibroids. But you know, in the present world, it's not just the group of us who is discussing. They will go a second opinion, third opinion, and second, third opinion may be Dr. YouTube, Dr. Google, and they'll come back to you, doctor. I put it to you. My fibroid is asymptomatic 3 years ago, but every health screening every year, it grows by 1 centimeter. Now, what going to say? You're going to say, okay, leave it alone. Then what if it becomes symptomatic? So you have to manage expectations now. Like I said, I'm a clinician, I'm on the ground. I cannot give a flow chart or algorithm, but I think what you would do really depends on the society we're dealing with. And the society means your standard of healthcare, the technology which you have, the skill level in which you are trained, and at the back of the mind, I always said, you have to really be very careful of what we say to patients now, because there's always a lawyer lurking around the medical centers and the hospitals.
I would like to just add one sentence to what Dr. Lee has told. First, yes, we have to follow the guidelines. So NICE guideline says symptomatic, but ACOG guidelines also says if it is going to affect the patient in any way, in a sense, psychologically also. So if the patient is getting mentally stressed over the fibroid, I think that should be taken as a symptom and should be taken care of.
Good. Very good. So you read the guidelines?
Yes. We do read it.
Okay, I will go for the last question now. This is to Dr. Narendra Malhotra. If the patient has multiple fibroids and she is unmarried, then with HIFU, should we go with HIFU or should we go with any drug, or there has to be any gap with medical line of treatment or HIFU?
So if it is multiple fibroids, the HIFU will have to be put into multiple places. So it will not be a simple procedure. So it has to be a medical management. And if she remains asymptomatic with medical management and improves, continue with that till she gets married, till fertility issues arise, then we will think about either a laparoscopy or continue the medical treatment.
Absolutely.
Thank you. Thank you. I would like to now end this session now. There are many questions which have been lined up. There's one question from Dr. Mohammed. This is the last question I'm going to take now. Dr. Lee, I want you to be very brief. In view of the COVID-19 pandemic, what is the unique advantage of HIFU?
Oh, okay. Okay. Number one, you have to observe all the guidelines, distancing guidelines, hospital guidelines, masks, wash hands and everything. The advantage of the HIFU is you do not need to have it in the core, the most important part of the hospital, which is your operating theaters. So you have it in one of the side rooms or departments whereby patients can walk in and walk out and everybody masked as per normal, and safe distancing because the patient is at least a meter away from you, and all the nurses, after monitoring the patient, they can look at the monitors. The anesthetist is there to make the patient quite comfortable. So I would say in view of COVID-19, and especially for symptomatic patients, instead of operating, because the HIFU room is really away from the hustle and bustle of the hospital. Whereas in the operating theater, patient has to go through all the reception area, theater, room 1, room 2, and then into the operating theater. And after that, you have to go into recovery. There's a lot of personal movements around. So I think HIFU is safer when you compare to present day surgeries.
Thank you, Dr. Lee. It was a wonderful to have all of you here with us. And quality content and science has no boundaries. We have witnessed first time in the history TOG webinar where more than 6,500 users have joined from all over the globe to hear esteemed speakers from Singapore, India, and we will continue with this trust with knowledge, because knowledge is infinite, knowledge is power, and knowledge has to be given to everyone. So thank you all of you, and I would like now Shriman to put our slide to show. We will be having the next global perspective on COVID, which is on 25th of April. We have got speakers from Israel, from Germany, from Italy, Milan, and we have our Indian panelists where we will be having obstetrics and gynecology practices during COVID-19. So I welcome all of you to join Indian Standard Time, 4 to 5 p.m., 25th April 2020. Thank you all of you to join us and have a safe and comfortable, absolutely great day. And we see that this COVID pandemic ends as early as possible. Thank you so much.
Thank you.
Thank you.
Thank you, Dr. Narendra. Thank you, Dr. Lee. Thank you, Dr. Anangani. I would like to thank our sponsors, Alembic, and our international sponsors, HIFU, from Chongqing Medical University, to be having partnership with this program. And it was a wonderful session. Thank you, all of you.
Thank you, sir. Thank you very much.